Babcock is a partner with Mountain Medical Physician Specialist. She's board certified radiologist specializing in breast imaging and intervention. She is medical director of breast imaging at McKay Hospital, where she's worked for the last 14 years. She enjoys outdoor activities with her husband and her horse, and she's here to update us on breast cancer. I didn't know whether to put your husband or the horse first, but
I keep them about equal.
when you get to 5 minutes, I'll give you a little 5 minutes.
Okay. Good morning. I appreciate being asked to come and talk to you guys, and I am thoroughly impressed with the volume of people in this room on day 3 of the conference. Good work. What I'm going to talk about today is breast density. And I'm going to talk about it because it's a hot topic nationally. It's in the lay literature a lot. Women's magazines are consistently now having articles about it. So patients are becoming somewhat informed. They're asking questions. They're wanting to understand. So it's important for all of us to understand the issues and how to deal with the issue of breast density. I don't have any disclosures. And before I talk about breast density, I just want to make a really brief and non-controversial, hopefully, statement about screening mammography. There's been a tremendous amount of controversy since the USPS task force guidelines came out in 2009 about whether women should begin screening mammography at age 40, whether it should be annual from that time. And after all the dust has settled, the vast majority of medical organizations have supported annual screening mammography beginning at age 40 and continuing until a patient's comorbidities make it not a reasonable thing to pursue. And our local hospital networks support that, as do most of our national organizations. And just so you can appreciate the impact that screening mammography has had, before the screening era began, there really had been no change in the death rate from breast cancer for 50 years. After the screening era took place, overall, there's been a 30 to 40% decrease in mortality in the 40 to 49-year-old age group, and in the 50 to 74 age group, a 15 to 20% decrease. So putting all of that together, we generally give a percentage decrease in death from breast cancer of about 30%. And one of the biggest studies that looked at this was a Swedish study with more than 100,000 women followed for more than 30 years. And one of the interesting things about that study, and one of the things that the USPS task force didn't take into consideration, was that in that study they divided women into 2 groups: those women who were invited to screening and those who were not invited to screening. Now, keep in mind that not all those women who were invited to screening had it, but even if they didn't undergo screening, the fact that they were invited kept them in the study group. Then there were women who were not invited to screening. Some of them did get screened under their own power, but they were kept in the non-screening group. So that study design is going to minimize any benefit shown from cancer screening. And overall, the benefit shown was 30% decrease in death rate. If you were to take those patients who were invited to screening but didn't ever have it, and put them in the non-screening group, you would actually see that there was a 63% decrease in death from breast cancer screening with mammography. So, how good is mammography? Well, there are lots of variables that impact whether mammograms can find breast cancer. And one of the myths that's out there amongst the community of women in this nation is that, well, if I've had my yearly screening mammogram and they called it normal, then I can't possibly have breast cancer. And probably there's none of us in this room who know that that is a correct statement. So there are a variety of factors that impact the sensitivity of mammography, but the one I want to focus on is a factor unique to an individual woman, and that is her breast density. When we talk about breast density, I meet lots of women who have been told and believe that they have dense breast tissue. And they've been told that from the physical examination of their breast by their physician. So I want to spend just a second focusing on the fact that what we think of as clinically dense may have absolutely nothing to do with what is actually mammographically dense. So the reality is that you cannot tell breast tissue type by the size of the breast, by the feel of the breast. A very fatty breast, mammographically, can feel very firm, very lumpy, and clinically dense, okay? So the clinically dense piece is, okay, it's harder for me to tell whether there's a lump in here that might be new or different or concerning, but that is dramatically different from mammographic density. So that's the number one thing. We have to, in terms of whether mammograms are more or less sensitive for breast cancer, that has to do with the density that we see on the mammogram. And you can just take the word density and you can switch it to white. That's what we're talking about. We're talking about how much white tissue is there on a mammogram. So on a mammogram, we can see both kinds of tissue that are normally in the breast. All women have white tissue, which is the glandular tissue where the milk ducts live, and all women have dark tissue, which is the fatty tissue of the breast. So, okay, that one. See on this mammogram, pretty much all dark, just a few strands of white running through it. We call this a fatty breast. Here is kind of at the opposite extreme of the spectrum. Look at all the white stuff, very little dark stuff. We call that an extremely dense breast. And as I've said, you can't tell the difference by feel. These two breasts may feel exactly the same, or this one, in fact, might feel softer than this one. Well, why do we care about that? What difference does it make what density you have? Well, the issue is that breast cancer shows up white on mammograms. So the amount of white glandular tissue that a woman has on her mammogram is going to impact a radiologist's ability to see a little early white cancer growing there. Think of it this way. This is a fatty breast. And you see how you can, kind of see through the jello? This is a dense breast. It's like a bowl of oatmeal. If you put a pearl in that bowl of jello, you can see it. Just like if you grow a little cancer in that fatty breast, you can see it. You don't have to be a highly trained radiologist to notice that thing. So mammography is enough in women who have that kind of tissue. But if you take the same pearl and you put it in this bowl of oatmeal, or the same cancer and put it in the middle of that white glandular tissue, it's invisible. So that's what we're talking about when we say mammography sensitivity for breast cancer varies depending on the breast density. So if you've got a fatty breast, it's going to be upwards of 90% sensitive for finding a cancer. But in women with dense breast tissue, especially in the old days of film screen mammography, which was what the USPS task force evaluated, only those studies, sensitivity of mammography was downwards of 60%. We've made a step forward by using digital mammography. We've now increased the sensitivity of digital mammography to about 70%. So another point I really want to drive home is I'll see women who say, oh, well, I was told that I have dense breast tissue and so mammograms are useless in me. And I don't want to have one because it's radiation for absolutely no benefit. And the thing is that a 70% sensitivity for the disease we're looking for is far from useless. So there isn't a woman on the planet who doesn't benefit from annual screening mammography. It's not that they shouldn't have it, it's that those women need something else. So how do you know if your patient has dense breast tissue or not? And radiologists are obligated by law, it's part of the MQSA guidelines, to include an assessment of breast density in the mammogram report that goes to the referring physician. And there are 4 categories. So we're basically dividing every woman into sort of quarters and saying this is where your breast density fits. Here's the first sort of most easy to see cancers, and we call that almost entirely fat. And that's the term that the BI-RADS system, which is the governing body that tells us how we're supposed to report mammograms, that's the term that we have to use. So watch as we go, and you'll see that there's a little bit more white tissue compared to dark in this woman, and we call that scattered fibroglandular densities. The next step up, heterogeneously dense, and the next step up, extremely dense. So all we're doing is sort of classifying them depending on the amount of white tissue that they have. It's a completely subjective call, but it's meant to convey to the referring physician what the likelihood is that a cancer could be missed. And so in this breast, with digital mammography, 70% of cancers can be seen, whereas in this breast, 95% of cancers, whoops, pushing the wrong button here. 95% of cancers can be seen, okay? So here are 2 different women. Both of these women have breast cancer. This woman's cancer has shown up in an area of predominantly dark tissue, sticks out like a sore thumb, don't have to be a radiologist to see that. This woman's cancer, however, is buried in here. You don't know that it's there, you don't know how big it is, you can't tell that it even exists. Here's another thing that contributes to our ability to see cancers. These are mammographic implants. They're white, so they look like big white balls on a mammogram. You can imagine how that can block our view to be able to see a small white cancer. So women who have implants, we use a technique where we push the implants back and try to pull the tissue forward. If this is sounding really comfortable to you, it isn't. But even though we do that, as you can imagine, we can't pull all the tissue into the image. So we're missing some of the tissue that's right next to the implant. This woman has the double whammy of having dense breast tissue plus implants. So we know that we're missing visualizing things. So the analogies that I explain to women are, the terms I use, I say sometimes it can be like looking for snowflakes in a snowball or looking for a polar bear in a snowstorm. It's there, it might even be big, but I can't see it because there's no contrast. So what do we do about that? Well, what we've done for a long time is nothing, and we've just waited until the cancer can be felt. The reality is, if you depend just on palpation to find breast cancers, they're going to be an order of magnitude larger than they would be if we could detect them with imaging before they got to that size. Most of the time, the horse is out of the barn by the time you can actually feel a cancer. Whereas if you can find it with annual screening before it's palpable, as you know, breast cancer pretty much has no other symptoms, so women don't know that it's there unless we find it. So what we need to do is add a test that improves cancer detection in the dense white glandular tissue. Radiologists have known for a long, long time that mammography is less sensitive in women with higher tissue density, but we haven't really done anything about it. The density issue, therefore, is not new. What's changed is the awareness of the density issue, and this all began as a grassroots movement started by a woman named Nancy Capello in Connecticut. And she was diagnosed with advanced stage metastatic breast cancer in her 40s, late 40s, after she had undergone annual screening mammography every year, just as she had thought she was supposed to. About 6 months after her most recent normal mammogram, she felt a lump, which she then went in, was easily seen on ultrasound, but had metastasized. She underwent treatment for that. And rather than sue everybody for having messed up, she said, how can this happen? What is the issue here? I thought I was doing everything that I needed to do. I didn't know there was anything else I can do, but boy, I could sure see my cancer on ultrasound when they did the ultrasound on me. And so she had a lot of connections, a lot of experience as an educator, an administrator. She was involved in the State Department. She understood how the legislature worked, so she proposed a bill that was passed in Connecticut in 2009, fondly referred to as Nancy's Law, that requires physicians to inform their patients about their breast density and to let them know that they could benefit from an additional screening exam with whole breast screening ultrasound. I won't even get into the controversy that this created, but what has happened since then, this map with all the red states shows the states that have adopted similar legislation requiring physicians to share with their patients what their breast density is and to let them know that they may benefit from an additional adjunctive screening test. So, how big an issue is this? What percentage of women are we talking about? 40% of women over the age of 40 have dense breast tissue. So not the majority, but a significant minority. 65% of those women are premenopausal, but a full 25% of them are postmenopausal. So most of them are going to be in the 40 to 49 age group. The other thing that the data is mounting on is the fact that women with dense breast tissue appear to have a 4 to 6 times increased risk of developing breast cancer. So they're at higher risk and it's harder to see. So what do we do? And I think I'm getting a little short on time, but there are a number of ancillary tests that are being explored. Obviously, if you're going to add something on top of screening mammography, and this is actually where I'm going to make a plug for screening mammography itself, do you realize that Utah is second last in the nation for the number of women who are eligible and insured who actually undergo screening mammography? So in our state, we have a long way to go just with getting women to have their screening mammograms. Then there's the 40% of women who have dense breasts and could benefit from something on top of that. There are a variety of additional tests, and what I'm going to focus on is whole breast screening ultrasound. What you want in a test that's going to help is you want it to be as low cost as possible. You don't want to increase the radiation dose. You don't want to increase the discomfort. You don't want to increase the number of false positive things that you're finding. And you've got to make it efficient so that large volumes of women can be screened without it being a huge deal. Many of you are familiar with the benefits of breast MRI in finding cancers. Breast MRI is extremely sensitive, also extremely expensive. In our hospital, a breast MR is about $3,500, 10 times more than a mammogram. Currently, the American Cancer Society guidelines for screening breast MRI are if you have a risk of 20 to 25% lifetime risk of breast cancer or higher. That does not include the general population of women, even with a mild family history, even with dense breast tissue. So what we're talking are this 40% group of women who are under the radar, under the risk of 25%, but still at risk of developing breast cancer. And remember, if you're just your average woman walking around with no family history, your risk of breast cancer is about 1 in 8 in your lifetime. So that's the other thing. Just because you have no family history doesn't mean you're not at risk. Every woman is. So that's not going to do it for the general population. You can't scan this number of women with MRI and not bankrupt the system and not lead to all kinds of unnecessary additional biopsies. Tomosynthesis, the data is mounting on tomosynthesis. That's where you squish the breast just like for a mammogram, but you do these bunch of slices. So you're kind of cutting through thinner slices, just like the old-fashioned tomography we used to use for all kinds of things. And data is starting to show that there's a 25 to 30% increase in breast cancer detection with tomosynthesis, and it's also helping to reduce the callbacks, which is a good thing, unnecessary callbacks and workups for women. But the data is preliminary. We don't have a lot of it yet. The problems with tomosynthesis, there's no reimbursement for it yet, no CPT code. It's longer compression for the woman. It's a little bit higher dose of radiation. And it takes twice as long for the radiologist to read it. So there are some things that have to be worked out before that can go prime time, but it's coming. So these other nuclear medicine tests, high dose, very costly, not great options right now. So I'm going to focus on breast ultrasound because in the Ogden-Layton region, we have screening whole breast ultrasound available to patients. So what's the difference with breast ultrasound? Well, just like you saw the white tissue on mammograms, that glandular tissue is also white on ultrasound. So white on mammograms, white on ultrasound, but whereas cancer is white on mammograms, cancer is dark on ultrasound. So right in the middle of the big white blob, we have a better opportunity to see a cancer sometimes on ultrasound. Here's an example. This is one of our patients. Extremely dense breast tissue. Here's the white tissue, but in the middle of it is this dark area. That was right in here, and that was where her cancer was. Would have been missed if she hadn't had an automated whole breast ultrasound with her screening mammogram. Here's another example. This woman had dense breast tissue and implants. You can see that we've tried to push the implant back as far as we can. Even in retrospect, I couldn't see where this breast cancer was, but here's her white tissue coming along both sides. Boom, cancer right there. This is a 7-millimeter cancer. It looks huge, but it's just a blown up picture. It would occupy about this much space in this mammogram. So there have been lots of studies evaluating screening breast ultrasound in breast cancer dating back to 1995. There's been a reluctance in the radiology community to adopt screening breast ultrasound because ultrasound is a challenging modality to do. It's very operator dependent. Cancer can be extremely subtle, just like on mammography. And it's how do you do it in a way that is time efficient, can handle large volumes of patients, and not totally disrupt your practice? Well, this was a study that was done, it was the biggest study in the US that was done looking at 2,600 women. And this was handheld, so the radiologist goes in the room, scans the patient by hand, all areas of both breasts. And I used to do this. And it's extremely time consuming. It's difficult because you've got an anxious patient right there. Every time you stop to try to figure out if something's real or not, or if it could be a cancer, they're like, what's that, what's that? And it's very difficult to go from that screening to diagnostic mode with the patient right there and actually do a good job and not miss things. And when you're scanning with ultrasound, a 5-millimeter cancer can goes under your probe in half a second. So if you blink, you can miss it. The biggest thing I found about doing handheld screening was that you didn't have any record of the exam to start using it year after year to compare. And that is the biggest benefit of annual screening mammography, is being able to look at every year and detect some subtle, questionable change. So people then said, well, wait, we need to find a way to do automated whole breast ultrasound so that a tech can collect all of the data, all of the images in some moving picture kind of way, or that a radiologist can then sit down in a dark room by themselves and batch read, just like we do screening mammograms, get into that Zen zone, focus, and go through and see if there are cancers. And we needed something that was going to be efficient, that we could do a large volume of patients on. It would be standardized, reproducible, and we would have records so that we could compare things. And this is the largest study looking at automated breast ultrasound to date, although there are a number that are underway currently. Looked at 4,500 women. They had screening mammograms and screening whole breast ultrasound on the same day. And this study found 23 additional breast cancers that could not be seen mammographically. So it turned out 23 were seen on mammography that couldn't be seen on ultrasound. 23 were seen on ultrasound that couldn't be seen on mammography. So that resulted in a 100% increase in breast cancer detection. And if you look at the kind of cancers that were detected, 22 of the 23 were invasive carcinomas, average size under a centimeter. Those are the easiest treated, most curable ones. The thing about it is you don't want to, increase your recall rate. You don't want to double the number of women you're having to have come back to work things up. You don't want to double the number of biopsies that you're doing that are unnecessary. And this study had excellent callback rates and biopsy rates compared to mammography. We have standardized ranges that breast images are meant to meet nationally. And we can do that with screening whole breast ultrasound. This is another vendor who's just come into the market. They found a 26% increase in breast cancer detection. So we do about 15,000 screening mammograms a year where I work. The national average for breast cancer detection from screening mammography is about 3.4 per thousand women screened. That's considered that means you're doing your job, if you can find 3.4 cancers per thousand. In our center, since we've been monitoring this since 2002, we find about 5 cancers per thousand women screened. In the first 600 automated breast ultrasounds I did, we found 4 additional breast cancers, couldn't be seen mammographically. So if we extrapolate that to a per thousand, we're in the 5 to 6 per thousand range. We're doubling the number of breast cancers that we can find. And here's just another example, dense breast tissue, and this woman had 4, 1, 2, 3, 4 little cancers. Here's another example of an obvious cancer on ultrasound hidden in her dense breast tissue. So if we're doing 15,000 mammograms a year, and 40% of those women have dense breasts, I ought to be seeing about, 6,000 women a year for automated breast ultrasound in our community. I'm seeing about 600. So women don't have to have it, but it is our job to let them know about their breast density, the implications of that, and to know that there are additional tests available. The ongoing issue is this, like tomosynthesis, there's no reimbursement for it, so women have to pay for it out of pocket. This is the price range. That's for a woman who's had a mastectomy. So we need to inform women, that's our job. We need to give them the opportunity to make the decision if they want to spend their money on an ancillary test like that. We are currently lobbying all the insurance companies to get reimbursement, but that takes time. And that's it. Questions?
Kathy, I have a question. Yeah, the rates of dense breast went down with age. Is that affected by hormone replacement therapy? Would that keep density up if a woman's on estrogen?
Yeah, breast density does decrease with age because of hormone changes. And yes, taking women off of hormones does allow their breast density to decrease more normally as they would, and that's probably impacted breast cancer incidence as well. But what actually in our society contributes to changes in breast density even more is weight gain over time. So if you've got a checkerboard with half white and half black squares, And as you're getting older, you're adding in more black squares. It looks like there's less white. There's not actually less white, it's just that there's more dark, so it sort of spreads it apart, and that's what results in decreased density as well.
My question is about the breast ultrasound as well. It's with the breast, by adding breast ultrasound, well, I've got two questions. One is what is the stage of cancer that you're finding with ultrasound that you would not have found with mammogram? You know, that 1 in 1,000 that was found with the ultrasound but not mammogram. What tends to be their stage? And the other question I had is, are you keeping track of false positives in that breast ultrasound group? How many women are being overtreated or being treated for a non-cancer in that group compared to mammogram alone?
Very good question. So the cancers that are being found with screening breast ultrasound are under 1 centimeter, and the vast majority are node negative. So we're talking about stage 1 breast cancer. The second question, in breast imaging, we have standards to which we are expected to adhere. National standards for how many women do we call back from screening mammography. How many women, of the women I get my statistics once a year, of all the women I call back from screening mammography, how many turn out to be cancer? Of all the women that I recommend a biopsy in, how many actually end up having breast cancer? And so yes, we monitor all of those same factors for automated whole breast ultrasound. And the national studies are saying there's no sense in adding in an additional test if we're going to be calling back more women, biopsying more women unnecessarily, then we're not serving the population. So we have to adhere to the same standards for automated whole breast ultrasound in order to get these statistics. So yes, we are meeting the same standards.
What are the numbers then, and how do they compare with mammogram alone?
So callback rates, interesting, used to be that your callback rate from screening mammogram had to be less than 10%. Recently, that was increased to less than 12% because the vast majority of practices in the state, in the country, were not meeting that criteria. Our callback rate at McKay-Dee is about 7%. So the number of women called back from screening mammography is about 7%. How many of the women called back from screening end up having cancer? So that's our individual cancer detection rate. And at McKay-Dee, and I actually took out the slide that had all our numbers in it, that rate should be between 2 and 10 per 1,000. And as I said, ours is 5. National average is 3.4. When someone recommends a biopsy, how many times does it turn out to be cancer? That should be a rate between 25 and 40%. And our rate at McKay-Dee is 32%. So we're falling in those guidelines. And same thing for automated whole breast ultrasound. You can imagine that our numbers are so much lower that we have to do a lot more patients before we can feel confident in our statistics with automated breast ultrasound. I think my time's up. Thank you so much.
Thank you.